There we go. Okay, so just starting out, what's the definition of a clinical trial? You'll see different definitions out there. This is a broad definition, the one that NIH currently uses. And that's a research study in which one or more human participants are prospectively assigned to one or more interventions, which may include placebo or other control, to evaluate the effects of those interventions on health-related biomedical or behavioral outcomes. So pretty general, clinical trial does not have to be randomized. It's something where you're basically taking somebody, giving them a treatment, and following them over time. And so you've probably heard of this kind of rubric of phase 1 through 4 clinical trials. That's something that's kind of been around for a long time. Here, phase 1 is usually looking at safety. So those are mostly when we're thinking about drug and device kind of trials. We're looking at safety first, preclinical studies. Phase 2 is when you start to look at efficacy, or does something work in a kind of defined small context. Through phase 3, you're looking more at confirming findings in larger patient groups. And then phase 4, which does not necessarily always happen for drugs and devices, but sometimes they're required to do these studies or more long-term safety and efficacy or effectiveness in diverse patient groups after a drug or device comes to market. Another framework that sort of overlaps with that when you'll see referred to more when you're talking about trials of behavioral and health services kind of interventions, is sort of this flow from efficacy to effectiveness to implementation. And on purpose, they made these bubbles so that there's overlap, because most studies, if you look at them, there are characteristics of each. So if we really know nothing about a particular strategy or intervention, we're probably looking at first step, looking at efficacy. Something's really new. We want to know, does an intervention or program or strategy work in a well-defined, tightly controlled circumstance? If it doesn't, then you stop there, right? Because you're giving it's kind of the best case scenario. I give this to this group of people and know exactly what's happening, and I can make sure it's actually happening, and nothing happens to the people, then that's kind of the end of the road. If it works in that kind of situation, then you want to look more broadly to effectiveness. So does it work in real world setting, generalizable setting? So you're going to look at a broader patient group, people with more comorbidities, people who are older or younger. That's kind of looking at the effectiveness space. And then we move towards implementation. Can it be delivered effectively in real world settings? So if you look at behavioral intervention, can you figure out a way that gets integrated into a broader clinical scenario? So the reason I bring this up is because a lot of times the phase that we think that we're in will determine some of our design decisions or the methods decisions for a trial. You may make a different decision. You would make a different decision about inclusion/exclusion criteria for an efficacy versus effectiveness trial, for example. So I'm going to talk a little bit first about non-randomized designs. I'm mostly going to focus on randomized clinical trials today, but before that, I wanted to talk a little bit about non-randomized, because you'll definitely see those in the literature. These are typically used when randomization is not practical or ethical. They sometimes do allow for control over treatment assignment, but not by randomization. So you might randomize clinic A to receive something, you might assign clinic A to receive something and then clinic B, but for various reasons you might not be able to randomize them, and so that would not be a randomized design. Main thing with non-randomized designs is that you have potential issues with what we call internal validity, because groups may not be comparable at baseline, right? If you're not randomizing people, there's some other way in which you're assigning them that may result in them not being the same in some or multiple ways. I'm going to just show a few different examples of some non-randomized trials in the literature, in the rheumatology literature, and just get your thoughts on what may be the potential problems. Okay? It's not to say that all these examples I'm going to show you are bad in every way, but there's some potential specific issues dealing with the fact that they're not randomized that I would say need to be paid attention to when you're looking at them and evaluating kind of what to do with that level of evidence. So this first one, web-based osteoarthritis management resource, My Joint Pain improves quality of care. So in this study, they got a national sample of patients with OA. They were recruited online advertising. There was a website, this My Joint Pain website was available to anybody who entered the study. And what they did with their analyses was compared the outcomes of people who did versus did not use the website. Okay, so they had all people come in and kind of registered or signed up. Some people used it, some people didn't. And then they compared the outcomes between those who did and didn't use it. Potential things we should be wary of here. And I'll say these are actually researchers we know and work with and respect. And I'm not up here to disparage them.
How did they recruit these people?
So it was online advertising.
Okay.
I don't know the specifics.
So we think that these are people that use the internet.
But people use the internet, which I would say in this case is probably okay because it's an internet-based management thing. So it would be, those would be people then in real life would be using it. Right. What about the aspect of comparing people who did versus didn't use it?
I mean, reliable access to the internet could be a socioeconomic factor that influences people that did not regularly use the website.
Right. So even people who initially kind of touched it, because everybody who touched it had some internet access, right? They could be different in that they weren't as comfortable with it. Yeah. So that's one reason. There could be a lot of other reasons that the people who use it versus didn't use it were different in ways that also affected their arthritis outcomes. So it could be that people with more pain or like, yeah, I need something more than this. So that's something to consider with this type of trial. That's not to say again that this is bad. This was probably framed as preliminary evidence to see if there's any promise for this kind of work, and then you would this intervention to work, and then you might do a more rigorous trial. So this one is interesting. This is pain coping skills training for people with elevated pain catastrophizing who are scheduled for knee arthroplasty. Again, quasi-experimental study. So in this group, they had an intervention group. There were people who were scheduled for surgery at 2 hospitals, basically. And they didn't do a simultaneous control group. But what they did was for their control group was they looked at a historical cohort of people who participated in an observational study of psychosocial measures before and after surgery from one of the hospitals that who got the intervention. So strengths and weaknesses to that as a control group.
Cheaper.
It is cheaper, right? Potentially because these are people for whom they already had some data. They had pre-post data and presumably the same time points that their intervention group got. So the difference being that one group got the intervention, one didn't.
Not the same surgeons.
I don't know. That's a good question. So it was only one of the hospitals, which is important. It may or may not have been the same surgeons. Depends on how historical of a control. So you're right. I mean, it also may have been some other time effects. You don't know, depending on how when that control group was seen.
Yeah, they're not necessarily representing the current cohort.
Yes.
They don't really know.
Yes.
How old.
Yes, respect to time and yes, age. So right. So we don't know just generally how comparable they are with respect to things that were measured versus might have been unmeasured. So there are sometimes differences in people who sign up for a trial versus don't. An observational study is different from a trial. So you might just have differences in that intervention group with respect to the kind of people who are more likely to say, yes, I'll be in this intervention versus people who just agreed to be in the observational study. So just something to pay attention to. And this actually was a kind of a pilot study. They subsequently did a randomized controlled trial of the same program. So this one, I'll just go through real quick. This was comparing patients with early RA who selected clinics that were basically integrated medicine clinics versus people who were in more conventional clinics. Okay, so what they found was there was no significant differences in outcomes between early RA patients who chose conventional versus integrated clinics. But I'll say here, just in the interest of time, again, we don't know how different those patients are in a whole host of ways. But they did provide here some baseline characteristics on the 2 groups. And you can see they are comparable in a lot of ways. But you look at, for example, duration of rheumatoid arthritis in terms of months. If they're all early RA, so there's not a wide difference, but the mean in the integrated group was 15 versus 10, 11 in the conventional group. And then if you look at their rheumatoid arthritis VAS, so patient rating of disease severity, you can see that's a little bit different, a little bit lower in the integrated group. So really important. Okay, their patients are different with respect to their overall disease, self-reported disease activity. So not a reason to completely discount it, but a reason to really look at it critically and say, before I really believe this, I want to see this done in a randomized trial. And then last example I'll show here is one that I think is a really good example of a non-randomized design. This is done with large administrative data, and that's a common place where you're going to see these non-randomized designs where people are looking using like big Medicare files or whatever else, other kind of files to compare people who received maybe treatment A versus treatment B. So here they were looking at Medicare data. They were looking at outcomes and costs from hospitals that participated versus didn't participate in NISQA, the National Surgical Quality Improvement Program. And what they did here is they had their hospitals that participated, and then their control non-participating hospitals were selected based on something called propensity score matching. And I'm not going to go into the details of that one because it would take forever too, because I confuse myself and you. But it's really a way to use variables that you carefully select to match, okay, intervention versus control, individuals or in this case hospitals. And so here they found no statistically significant improvement in outcomes like mortality and readmissions before versus after enrollment in NISQA, okay, intervention, or the participating versus not participating. Had they not matched them, the participating, non-participating, my guess is they would have found differences, because there are probably systematic differences in hospitals that participated versus didn't participate, like size and a whole list of other things. So before I go on, questions about non-randomized trial designs? It's a really broad overview. There's lots of different methodological considerations that go into those. But yeah.
You know, like the genomic personalized medicine that's taking off recently, could you possibly do a non-randomized trial for something like N1? Because that's kind of been something that's on my mind, you know, if we're going towards more personalized medicine for individual patients, then how can you study whether that's actually efficacious or not?
For a certain individual?
Yeah.
Yeah. So there is a whole other branch of a whole other methodology called N-of-1 trials, which I think is maybe different than what you're talking about. And I don't actually know a ton about them, but that's, if you're interested, that's something you can look up. It's just the whole methodology behind N-of-1 trials. But when you're thinking about genomic medicine, precision medicine, there's other, I think ways within clinical trials that you can get towards that, individualized medicine. And some of that is really, whether it's in the context of a prospective trial or using available data, looking at those factors and trying to use some statistical methodologies to get at what predicts response, right? So if you have a really large trial of a particular drug therapy and you have genetic data on all the participants, you can then do some analyses, like we were talking about in the last session, sub-analyses to look at whether a particular genetic profile is predictive of response. So I think that's an area that we see growing a lot. You know,
and it's
precision.
more after, like you said, it's taking the big trials and then having available data and saying, would someone have done better with this drug?
Or integrating them into clinical scenarios where they're just giving these treatments, right? And
Yeah.
potentially a non-randomized way, just collecting that information, and so you can look at the hospital data or administrative data to see if you can pick up some signal for who's, you know, whether genetic profiles or other things are having a response. Yeah. Okay, so let's talk about trial designs. Now I have some slides at the end that deal more with specific methodological issues around trials, and we may or may not get to that. If there are particular things that you're interested in, we can focus on that too. But what I thought I would do first is really spend time talking about the broad topic of designing a trial. What's the overall framework? The most common trial design you'll see is at parallel groups. This design, everybody is randomly assigned to one group, and randomization could be at the individual level, but it can be stratified based on participant characteristics. When we say stratified, we mean that so we have a different randomization scheme for men and women, for example. Of course, we would stratify because, I would say, a combination of two reasons. One is that we think there's a chance that that characteristic may be associated with treatment response. Like, I think that potentially women will do better with this treatment than men. So I want to make sure that there's an equal number of men and women in each of my groups. The other reason is that you think that there's a chance you would get imbalance in your groups. And that can particularly happen if it's an infrequent characteristic. So let's say you think that there's a particular racial or ethnic minority group who may do better or not as well, but it's a small group. So there's a chance that when you randomize, you can end up with most of those people in one group or another. that's a reason you might want to stratify it. So what that means is that that group has its own randomization scheme, so that you're assured that at the beginning and that for both the groups have an approximately equal number of people in that group. You can't stratify on everything. You can stratify probably 1 or 2 variables in a given trial. You might think, oh, somebody who comes in with worse pain is probably going to not do as well on this intervention. And I would argue that that's not something you want to necessarily stratify on, because pain is a continuous variable, right? It's not X and Y. And so just based on randomization, you're likely to get a pretty equal distribution of pain scores. Where you really think about random stratification is those sort of more small buckets of people or characteristics. You want to ensure that they're balanced across groups. Okay, so that was a little bit of a rabbit trail. Parallel groups is the most common trial design you'll see, but sometimes it's not appropriate or feasible to randomize at the individual level. We'll talk about those kinds of designs in a bit. This is just an example of a study we finished here recently, looking at physical therapy versus internet-based exercise training in people with knee osteoarthritis. And so here people were randomized to either standard physical therapy, internet-based exercise training, or waitlist control group, and you can see their outcome assessment points. A couple things I'll point out here. You can see by the ends, the group sample sizes are not the same by design. It's 140 each of the treatment groups and 70 in the control group, and that's a strategy you can use legitimately to boost your power. And that's something, so that's again a whole different talk that I'm not qualified to give. You got to do that carefully and with the advice of your friendly neighborhood statistician. That's a legitimate strategy. And then another thing I will just point out about this is we had, for this study, 2 different sets of hypotheses. One is what we call superiority hypothesis, and that's the most common one you'll see in the literature, is something better than something else. So here we were looking at, is physical therapy better than control, and is internet-based, exercise-based better than control? And then we also had what is called a non-inferiority hypothesis, and that is saying, is internet-based exercise training no worse than physical therapy? Okay, is physical therapy being the gold standard? So that's non-inferiority, and one thing about non-inferiority hypotheses is that they require a higher sample size, just for consideration. Okay, factorial designs. This is kind of a variant on a parallel group design, but here each participant is randomly assigned to a group that receives a combination of interventions or non-interventions. It allows you to look at interactions between treatments. So here's an example where, let's see, it does work. Okay, so just focusing here, one group got manual therapy, and these are people with hip or knee osteoarthritis. One group got exercise, one group got manual therapy plus exercise, and one got usual care. Okay, so similar, it's a type of parallel design, but you're particularly interested in individual treatments and their combinations. Okay, crossover design. Here, you don't see this a ton, but it's where a participant serves as their own control. So rather than somebody just being in group A or B, you're in both group A and B at different times. There are some advantages here in terms of statistical power and sample size, but a caveat is you have to be able to watch out your treatment. So if you have treatment A, like let's say treatment A is weight loss and treatment B is control, you can't really wash that out, right? You had a weight loss intervention. You can't really, things are now different, hopefully. But here's an example where it was appropriate. This was looking at a laterally wedged, wedged insole for treatment of knee OA. So here, people are assigned to have the wedge or neutral insole. They have follow-up assessments, 4-week washout period with no insole, and then they get baseline assessments again, and then they're reversed. Okay, so again, statistical advantages to a certain degree, but it has to be a treatment where you can withdraw it and you kind of go back to what you would expect at baseline. Okay, cluster randomization is where pre-existing groups of patient participants, like clinics or patients of a particular provider, are randomly assigned to receive or not receive an intervention. And this goes back to what I was mentioning earlier, that sometimes you can't randomize at the patient level. Let's say I wanted to do an intervention where all patients were going to get a new, I'm trying to give a good example, like a new behavioral intervention that their primary care provider was going to kick off or something like that. I really can't have that provider ideally treating intervention and control patients because there's a risk of contamination. They're going to change their behavior for control patients, because of something we're having them do with an intervention patient. That's when you'd want to use one of these types of designs, right, like this. When an individual level randomization could result in contamination. There's more logistical challenges than patient level randomization, and you should really only use this design when you have to, in my opinion. One of the reasons that you risk imbalance in patient characteristics across groups. So we've been talking about randomization. If you use individual randomization, you're most likely going to be fine with respect to balance of key variables between the groups. But if you randomize things like clinics or provide groups of patients of a provider, you don't have that same assurance that by randomizing at that cluster level, the patients across those groups are going to be the same. You can try to do that. I'm going to show you some examples here in a minute. The more clusters you have, the better off you are in terms of various things, but it also makes it logistically harder. And you can also try and use the information you know about clusters to randomize them equally, so you can pair clinics. Let me show you some examples here, and I'll get to some of those points. This is a trial we did at the Durham VA down the street. Here we had clusters where 38 primary care providers, and then we had so about 10 each of their patients, hypothetically, although we have providers who put their jobs in the middle, and so this is what I mean. There's just lots of challenges to this, but so some providers had more than 10 patients, some had less in order to get to our full sample size. Here, we actually did fine in terms of our clusters being equivalent. I don't think I'm going to show you those data, but we didn't have any randomization issues here. We had a lot of clusters, 30 clusters, but only 2. They were divided across 2 groups. And all of these providers were in one VA, so there really wasn't a whole lot of difference in the patients they were treating. Here's another one. This is the same, and just to back up here a little bit, the 2 studies I'm showing here, it's the same intervention, just done in 2 different trials in 2 different healthcare systems. And the reason we did it at clustered levels is because we were asking primary care providers to do some interventions surrounding recommendations for osteoarthritis management. Here, it's a little bit of a different design. This was done at the Duke Healthcare Network. We randomized 10 clinics, okay, so a smaller number of clusters here, and we randomized them to first at the clinic level. 5 clinics got the provider intervention, and 5 clinics did not. And then within each of those clinics, half of patients got the intervention and half did not. So you ended up with, it's actually a factorial design that we just talked about. Some people got patient and provider intervention, some provider only, some patient only, and some usual care. So what I want to show you is that these are the baseline characteristics of our patients. It was not a disaster, but there were some things that's a little bit hard to see. I'll just tell you the important point here. What I've highlighted here is the WOMAC score, so their baseline pain, stiffness, and function. It's around 39 for the total sample. And here across the groups, 36, 41, 38, 40. They're not wildly different, but they are definitely more different than you would expect in a parallel, in individual level randomization. You'd expect that probably within a point, I would say. So what ended up happening is that there were some clinics that just saw patients who were older, sicker, some who were younger, healthier. When we started the study, we had our 10 clinics. We knew who our 10 clinics were going to be, and we tried to pair them according to ones we thought would be similar. Like there were a couple of rural clinics in Henderson and Butner. We paired them. The one was a provider intervention, one was provider control, because we thought their patients would be similar. So you can try to do that, but you can see that it does not completely work because you can't know everything about the characteristics of patients in a cluster before you start. So that's a kind of a caveat about these cluster randomized designs, but they're powerful for a lot of trials. Stepped wedge is a special case of a cluster randomized control design, and this involves random sequential crossover of your clusters, again, which are clinics, facilities, providers, from control to intervention until all clusters are exposed. So every cluster contributes both to intervention and control group. Okay, so it's different than this, where a cluster was either intervention or control. So here. Actually, this is the most kind of common scenario here to see. So you have the clusters here. So cluster 1, this is its control period. Then it crosses over, and here's its intervention period. Cluster 2 here. Okay, so you can see they're they're contributing differential amounts of data. You're doing data collection in these time points. Okay, here's where the intervention begins. This is different only because there's a washout or a transition period where you're not collecting data, and that may be where you're like training staff to do an intervention or something like that. So let's look at some examples. Well, first, just a few advantages and disadvantages. So all clusters can eventually have the intervention. So that can be an advantage in recruiting sites if you're going to clinics and saying, well, you might be the control clinic and you just won't get anything. Well, if it's a clinic that really is interested in whatever topic you're studying, they may be like, yeah, I'm not really interested. And actually, these designs can have better performance than a parallel design if your clusters are heterogeneous. Okay, so again, thinking back to the scenario we had in our Duke study, we had our clusters were different here. It doesn't matter quite so much if your clusters are different because everybody's contributing to control and intervention. However, if this cluster is really different than the rest, or this one, you still can run into some difficulties because your clusters are differentially contributing data to intervention control. So it doesn't completely wipe out that problem, but it does help to some degree. Some disadvantages, you have more clusters exposed to the intervention in later stages. Okay, so that there can be confounding by temporal trends. And then sites have to agree to be in the begin their intervention at their specified randomization time point. And I've been involved with a couple of trials at the VA recently where we're doing this type of design, and it's been a challenge for various, because you can approach a site and you can say, okay, you're going to start in 6 months, and they can say, no, we need to start. So I'll give you an example. So at the VA, we're trying to do a trial of an inpatient mobility, inpatient walking, getting people to walk in the hospital to reduce adverse events and improve function. And we wanted to do it at our local network level, so North Carolina, Virginia, kind of, because it was easy. There wouldn't be as much travel. Well, as soon as we started talking with the VISN, the network, about it, the VISN director said, we're having some pressure to do an inpatient mobility program. We're going to roll this out to all of our sites right now. And so they did, and so they were all off the table. Our study team is still evaluated it for them, but they would not wait. Essentially, we said, well, yes, this is great. We can do this trial right here. No, not happening, because they said this is my 100 days initiative. Everybody's rolling out in the next 100 days. So you see all kinds of scenarios like that. Yeah.
Do you often have to incentivize participation in these trials, and how do you do that?
Yeah, that's a good question. So the studies I'm talking about, I'm a co-investigator on, not the PI. So I don't know this as intimately as my colleagues do over there, but I've seen a bit of their experience, and yes, for sure. I mean, one of the things is trying to hit a sweet spot where your intervention is something that the health system or clinics you're involved in, that's high priority for them. You will definitely get better engagement there. There are practical incentives you can give people, like giving people a lot of support to implement their intervention is a big one. Providing just guidance and kind of, being a constant source for them asking questions as they're going on. So those sorts of practical incentives. There usually aren't incentives we can give clinics or providers the same way we give like monetary ones, the same way we give patients. Sometimes in a trial, you'll be able to, depending on the funding source, you might be able to provide a person, like a clinical person. Another study we're getting ready to start up is, actually it's not a stepped wedge, I don't think, but it is one where we're trying to randomize clinics to do an intervention, one of 2 interventions actually, and an incentive for one of the interventions is that we're actually providing a telephone activity coach. Because our funding allows us to do that. With some, it doesn't allow that to do that. You have to use existing clinical infrastructure. So yes is the answer, but it's often hard to find the incentives that are really, take some figuring out and work with clinics and try to figure out what those incentives are, like what's gonna hit that sweet spot for them. And often involves going to their, not just leadership, because you also don't want to go to leadership and have it like clinics say, hey, the hospital director said you're doing this.
It's considered coercion, the IRB, it can be an issue with the IRB. We ran into that several years ago.
Yeah, so you gotta worry about those kinds of issues, and then also just the morale kinds of issues of mortal management and frontline staff not really appreciating it, so.
When we
it's-
did the health literacy toolkit evaluate, it wasn't a trial, but we were evaluating the practices. We gave each practice $1,000, but they chose, most of them chose to like do something for their staff.
Yes, and we did that in that Duke study. We can do that in the VA study. In the Duke study, we did that too. We said, well, here's what we'll, and it technically was compensation for us being in their space,
Right.
but
Yeah,
they did have
that's how
some
we-
money to be put in their fund when they did
Something
development
nice.
or whatever, yeah. Okay,
So I do have a question about the design of the step wedge.
Yeah.
So maybe I'm just not understanding how it works, but for the controls versus the groups that you're analyzing, how the time points, wouldn't you have way more numbers of control patients in the later stages of the step wedge rather than, so can you like really control that cluster? Isn't that gonna mess with your power? Do you have different samples for each cluster?
yeah, so sample size is a different issue with step wedge for sure.
Because to me, it looks like, you have like 90% be control in the last
Okay, so actually these are not, this is calendar time.
time.
Your time points, so your data collection points would be here and here and here for each cluster. So this cluster contributes this much control data. So let's say we have, maybe we have 30 patients here, right?
Yeah.
We're getting pre-post data on, and then we implement this intervention. There's more time passing here, so you're gonna get 500 patients here, you have data here for here. And then the opposite is true for this.
So they're not serving as their own controls?
No, so it's a little different. You don't technically serve as your own control. You just contribute to control data. It's more similar to just a parallel group in terms of, so it's not a crossover. It's a good point though, because it does make it look like it is. It's not a crossover where you're serving as your own control. You're just contributing to both control and intervention data. But instead of just being one or the other, you're both.
That
But
makes sense,
by staggering when intervention starts, you end up with approximately the same amount of patients who are control patients and intervention patients. But that's not true for an individual cluster. Right? Every individual cluster, like there's only one or two of these who have approximately equal sample size for control and intervention. That's why it's still important that you consider who your clusters are going to be. If these clusters are really different from these clusters, then you're kind of skewing the number of patients. These clusters have more patients in the control, intervention data. So if these patients, these clusters are really different from these, you might end up with some imbalance still in what your control and intervention patients look like. Does that make sense? Yeah.
What is the advantage of having a stepped wedge instead of just having like a single time point for all the clusters where they switch from control to intervention?
I mean, one is a practical one where a lot of these are sort of this is often used in health services and implementation kinds of research, and you often can't do it. You often can't roll that out to all clinics at the same time. In terms of methods, I'm not sure that there really is an advantage. It's a good question. I'm not sure, honestly. You have to think about that a little bit more. But the practicalities are definitely a factor.
And logistics is important.
Does it allow you to differentiate between like different different treatment durations? Or is that something that you would need to address in a stepped wedge? Like if it's gonna take 6 months for the treatment to have efficacy and the people in that 6th group only are on the treatment for 1 month.
Yeah, so you want to factor that into your design for sure. So you want to make sure that your intervention period or your control period is long enough that it encompasses your pre and post period. So if you think that like in a more standard trial design, if you think, well, my outcome points need to be baseline and 6 months after somebody starts a treatment. And honestly, when these kinds of designs, they're usually not like drugs. They're usually like care management interventions or whatever. But the same principle. If you want that much of a time point, then you need to factor that in to your pre-post, to how long your control window is. So you need to have enough time that your patients who start here have enough time to get their pre and post before the study ends. Okay. So you have to figure that in into how long a given cluster is in a controlled intervention period.
So I think you just answered this, so just to make sure I understand. So you're saying that in a stepped wedge study, you would not compare the sixth person to the first person in terms of like, did the intervention work better for that longer period of time versus the shorter period?
Yeah, so the intervention duration and the outcome assessment points are the same for everybody. Okay, so if you're in clinic A and you're in the intervention period, you're in cluster 1, you get the intervention period, your intervention should be the same duration as this person who gets it here. So you have to make especially the last clusters, the time period that they're in the intervention group has to be long enough to allow for that.
So it should have more people in the intervention
Correct.
in
Correct.
that first row,
Correct.
in that cluster.
Yeah.
But they're all getting the same time.
Yeah, just to you could have people here in a control group that, let's say they enter the study here. Whoa, let's say they enter the study here. Their follow-up point might be here, okay? But you have to think about whether that may or may not, and that's sometimes why you need a washout period, because you need to make sure that if they're counted in this control period in that cluster, their follow-up can happen after, but you have to make sure that in that interim time point, since their cluster has crossed over, that they're not exposed to the intervention. So it just depends on what the intervention is. So our inpatient mobility program, for example, that's a discrete time. It happens in the hospital, then they're done. They've either got it or they didn't. So let's say they're in this cluster and they're in the hospital here. They could have their follow-up, because we do a follow-up 6-month phone call. But they're out of the hospital, there's no chance that they're going to get exposed to the intervention at this point, okay? So their follow-up might be out here, but that's okay, because even though their cluster has crossed over, they have not crossed over. Simple, right? That's why you should just do a parallel group individual level randomization study. Okay, so here's a couple of examples. I'm not going to go through them though, because this is just illustrative for some OA studies, but you guys have access to these slides. So these are actually this one and this one are arthritis-related trials that are going on now in some different healthcare systems where they're using these models to study care management interventions in primary care settings. So if you're interested in practically seeing how people do this, these are protocol papers. This one is a pilot study that they talk a good bit about how they're doing it. So interesting stuff. Okay, I'm going to talk a little bit about adaptive trials or interventions. So this is not so much about the design of the trial so much as the design of the intervention, although it can be both. So generally, these are situations in which an intervention is modified in intensity, dose, and or type at a specified time point based on particular response, participant response, and or sequential randomization. So let me break that down a little bit. And I'll do that in a minute. But so an advantage here is it can mirror a real-world clinical scenario. So if you have a patient, they try drug A, it doesn't work, what do you do with them next, right? So this is kind of trying to model situations like stepped care strategies where you want to have more than just this treatment A work. You want to know does an overall strategy of kind of adjusting care work. So there's some efficiency in that. This is just doing multiple trials of different parts of the treatment. They can be complex in terms of decision roles and is estimating responders, and I'll illustrate that in a minute here too. So this is a pretty simple version of an adaptive trial that we're just finishing at the VA down the street. It's a stepped exercise program for veterans with knee arthritis. So people, and you can see here's this is another illustration of differential sample size because of power issues. People start with an internet-based exercise program. That's what this is. We assess them after 3 months, and then we see if they met a certain kind of response criteria. Basically, did their pain and function improve to a clinically relevant degree? If yes, they go on their way. They keep using their internet-based program. We helped, we think, they're fine. If they didn't, we give them some phone support. We assess everybody at 6 months and look at those response criteria again. For people who are here and still using the web-based program, if they've kind of reverted and they're no longer experiencing clinically relevant difference, we cross them over and give them some phone support. For this group that already have the phone support, if they still have not met clinically relevant improvement, we send them on to physical therapy. Okay, so that's just an example of trying to use a situation here. We're particularly interested in trying to reserve PT for patients who may need it most because of the VA. It's a limited, there's just limitations on the number of PTs they have. Not everybody wants to go to PT. The VA is the payer and the provider, so they're interested in these kind of interventions that are cost saving. So that's an example. And one thing I'll say here is we're stepping up people or not based on response criteria, but we're not re-randomizing, okay? That's in contrast to what people refer to as SMART design, sequential multiple assignment randomized trials. And I'm not going to go through all the details here, but this is an interesting paper if you want to read it. And this guy, Danny Almiral, is a statistician who used to be here at the VA and does a lot of work in these kinds of trials. So he's a good person to look up if you're interested in them. So they start off with a particular treatment, weight management treatment, I believe. And they're randomized then to different assignments here. Then they deal with some things about non-response, and depending on that, they may or may not be re-randomized to some different scenarios. This is really complicated, and one of the difficult things here is that you have to have a good idea of response versus non-response, because if you randomize here, you may have nobody who randomizes, right? So here, responders don't get randomized. Non-responders get randomized. Well, if everybody is a responder, then you don't even get to do this part of your trial. And I know people who have done trials like that are SMART trials, and they just didn't even get to do a piece of their trial because everybody responded or nobody responded. And so that's just a scenario where if you're gonna engage in that kind of trial, you have to have a pretty good idea of what you would expect in terms of how many people are gonna meet your criteria for when they get randomized again. So they're really powerful and cool designs, but I would tread lightly personally. Okay, pragmatic trials, you hear a lot about this. I'm not going to go into detail, but these are trials that are on that implementation effectiveness side of the scenario we talked about way at the beginning. These are designed to study intervention in a real-world clinical setting. If you want to learn more about this, I've put a couple of good websites here, but I just emphasize that pragmatic, trials can be pragmatic in certain areas, but not others. And when you're trying to, and often those are just decisions you make at the outset based on feasibility or based on what you think is important to be pragmatic versus not. And this PRECIS tool is a way to do that. You can decide when you're designing a study, or do you really care about the setting? Do you care that that's really generalizable and really pragmatic, or is not? Are you more concerned about like your eligibility and provision criteria? Okay, so that's a good source. These are good sources for learning about pragmatic trials. And that's actually good timing. That's the end of what I was going to talk about this trial designs. Other topics that we can briefly touch on if you'd like to is just how you select the control groups, usual care versus intention control, participant selection, and there's a bunch of other decisions